Hi, hello, good afternoon, good evening, and good morning. We welcome you all for joining us today for the webinar on sexual and reproductive health and rights of Indigenous women, girls, and gender diverse communities living with HIV/AIDS in India. So, we welcome you all for joining us today. Next. Okay, my name is Sangeeta Gowri, and just a brief introduction about myself. I work with sexual and reproductive health matters, and I also work with MARG in the capacity of advisor. So MARG stands for Maldhari Rural Action Group. So, and it's one of the co-organizer of this webinar, and it works with pastoral community in Rajasthan and in Gujarat states of India. Next. So this is how a 90 minutes webinar look like. We have a welcome address by Deepa Pawar. It's going to be 5 minutes. Actually in CAN, that is Canadian Aboriginal AIDS Network, there is a practice. Whenever there is a meeting or there is a webinar, they always invite an elderly from indigenous community to inaugurate that meeting and seek the blessings. And this webinar is in India, and we do not have a culture of inviting elderly, but we thought that we would invite one leader from the indigenous community and would ask that person to give a welcome address and would ask whatever the practices are prevalent in the community which are relevant to today's webinar. So that is going to be a welcome address for 5 minutes, and after that we have a 10 minutes presentation. So one first presentation is by Ken and will be given by Patricia, and she will give an introduction about this whole about this global research initiative. And then the second presentation is by Manjula from WHO on the guidelines on SRHR of women living with HIV. And the last two presentations are of 15 minutes each. And those two presentations are in an Indian context, how these guidelines can be contextualized in India, can be operationalized in India, and what are the challenges and opportunities they presented. So this is how, and the last 30 minutes, and to be precise, 28 minutes will be question and answer sessions. And you can post your question anytime in the chat box, and those questions will be taken in the last half an hour session of the webinar. And in the last 2 minutes of the webinar, we have a vote of thanks by Nisha. Thank you. Next. So before we begin, we just want to share that this webinar will be recorded, and recording will be available to you. And you can submit your questions anytime in the chat box. And for more information, you can visit to the CAN website. It's there. You can look at the web address. And for the handouts of the presentations, as I've shared, there are the 4 presentations. So for the handouts, you can see in the control panel, there is a link. So you can download the handouts there from there. Next. So now I will invite Deepa Pawar for the welcome address to share what are the practices which are relevant to women's sexual and reproductive health rights. So I'll introduce Deepa. So Deepa comes from notified and denotified tribal community of Maharashtra. She's an activist and she's working for last 2 decades with the communities on various issues. And she is recipient of the prestigious Martha Farrell Most Promising Individual Award, and that award was given to her in 2021 for her outstanding work for her community. So welcome, Deepa. So the floor is open to you. Floor is to you,
Yes,
and you have a 5 minutes. Yeah, and
yes.
all the best.
Thank you.
Yeah.
Thank you, Sanjita. Johar and Zindabad. Many congratulations to you on this process. Such grassroots discussions around guidelines for women's sexual health and dignity is a positive sign that women's sexual reproductive rights are being considered with importance. We can never negate the close relationship Adivasi community have with nature. But it is important to throw more light on this. We can understand this through some examples. Many discoveries around women's sexual reproductive health and treatment have been made by Adivasi communities. For example, massage of pregnant women done in home based methods, The oil used in these massages are not bought from any market, but made by Adivasi by herb and they collect or grow. The measurement for such recipes have been determined by them that they have discovered and use ingredients such as ajwain, cloves, which have pain relief and muscle strengthening properties in these oil, shows how they have a scientific perspective about women's sexual reproductive health. Another example is how during women pregnancy or delivery, various nutritious food items are given. Brews, laddus with methi seed, flax seed, dried coconut, date, and many other items are made by Adivasi communities. These are very beneficial to new mothers. These are not too complicated to make. Similarly, Adivasi communities not only are aware that women need rest during such time but provide facility for such rest. Women are also given weapons with more such beneficial items such as ajwain, black pepper, bitter stick, dalchini, etc. by the Adivasis. As per location and particular community, the exact ingredients change, but they all have these practices for strengthening women when they are at low immunity level. Not only these, but Adivasi group also have tradition of folk songs about sexuality, thus providing healthy spaces for their expressions. These are forms of community education or dialogue regarding these matters. There are many historical sources that tell us how respecting, such as through prayers, women reproductive organ is a part of Adivasi tradition. In Guwahati, Assam, in India, there is a temple called Kamakhya, which is living example of old Adivasi tradition of worshipping the women vagina. This tradition of celebrating menstruation openly offer a strong counter to patriarchal system that belittle and render menstruation as untouchable. Till today, young women in some Adivasi communities or groups have the freedom to choose their partner after exploring their mental and sexual compatibility capacity with each other. One another note, in the same way that there is a political over the bodies and reproduction of women, there are fights over the resources, produce and wealth of forest, water and land. The Chipko Andolan led by Gaura Devi and many other Adivasi women and men that fought dominant forces to save forest can never be forgotten. There are young Adivasi women history like Nangeli who raised her voice for her body right and made it clear that body dignity is a fundamental right of women in such a fearless and resounding manner by cutting off her breast and giving up her life to make her point. Friends, the way that nomadic indigenous Adivasi tribe continues to stand strong till today with the environment for its nature, protection, reproductive strength, nature specialties. Similarly, they stand with women dignity of body and sexual reproductive right through treatment, research, inventions, support system, creating community resources, movement building, and demanding these rights. With these, I conclude my thoughts and wish to say that we will certainly take ahead this discussion strongly. Thank you.
Thank you, Deepa. I think that was so wonderful. I think you shared all the practices prevalent, like, all the communities, tribal communities in India. You covered from northeast to south to north and west. I think that was very wonderful. Thank you once again. Thank you. And yeah, we were lucky to have you and to hear you. Thank you, Deepa. And with this, I would invite, sorry, Adus, can you go to the next? Yeah. So after the welcome address, we have four presenters today. So one is Patricia from Cannes, who is leading this global research initiative, And then we have a Manjula from WHO, and then we have a GS Shiriniwasan from UWI.Tech India, and then we have a Muni Kumari from Jwala Shakti Samu. So both Shiriniwasan and Muni, they will share their insights from their experience of working with tribal communities in India. And can we move to the next slide, please? Yeah, so I'll invite Patricia for her presentations. So Patricia by training is a physician and epidemiologist. She has 2 decades of work experience, public health experience in developing and managing various community development programs. She has an extensive experience of HIV and STBB programming and research, particularly of working with marginalized groups. And she is a global research manager at CAN. Over to you, Patricia. Floor is yours. And you have a
Thank you,
10 minutes.
Sanjita.
Thank you.
Thank you, Sanjita. So, good afternoon, everyone. I want to thank you, the panelists, for their commitment to Indians, Indigenous women and girls, and the seminar's audience. I am Patricia Maicha, the Global Research Manager of Communities, Alliances, and Networks, a national Indigenous non-profit organization in Canada dedicated to responding to HIV, AIDS, hepatitis B, STBBIs, TB, and mental health. Established in 1997, CAN is a crucial voice for Indigenous people living with or affected by HIV or hepatitis C. In 2017, the WHO released a consolidated guideline on the sexual and reproductive health and rights of women living with HIV. Evidence from this report highlighted the inequitable access to quality health services for Indigenous women living with HIV and their extreme vulnerability to gender violence and sexual and reproductive rights violations. This is the documents in which this research was based. The long title of the research is this one that you can see. And this project is being carried out in 7 countries: New Zealand, Nigeria, Nepal, India, Peru, Guatemala, and Canada. Next, please. The short title is Measuring Sexual and Reproductive Health and Rights, Responding to the Needs of Indigenous Women and Girls in a Global Context. Next, please. So throughout this project, Indigenous knowledge will be integrated from the design, development, dissemination, and evaluation, and we will work to defend the principle of equity, gender equality, and sustainable development among all the population we will interact with. Therefore, it is a paramount that Indigenous ceremonies and traditional activities are honored throughout the project to help guide safe and healthy relationships in a good way. Part of this process is peer education and mentorship concerning sexuality, relationships, and cultural teachings that are empowering, knowledge-based, and free of stigma, prejudice, and judgment. In this way, Indigenous women and girls are equipped with the knowledge to make the best possible decisions adjusted by others and will be able to decide for themselves. For example, if they want to have children, how many, when, if they want family planning, if they want to have sex or not, and with who. The project seeks to articulate how to respond effectively to the sexual reproductive health rights of Indigenous women, girls, and gender diverse Indigenous population in a culturally appropriate ways and specific contexts. Next, please. The research questions for this project are based in underlying the cultural and structural issues Indigenous women and girls face in accessing sexual reproductive health rights. What also are the opportunities since the point of view of cultural and structurals that could increase the Indigenous women and girls' access to sexual reproductive health rights? And what are appropriate culturally responsive solutions to advance Indigenous women and girls for the sexual reproductive health rights. And the last one is how do we build indigenous men's and boys' capacities to advocate for optimizing the sexual reproductive health rights of indigenous women and girls. In addition to these questions, we are developing research questions that are specific for every country according to their circumstances. Next, please. The overall objective of the team is to develop an indigenous framework that promotes better well-being through different goals. I am going to say some of the most important goals for our project. The main is a better understanding of the barriers that affect the data collection, analysis, use, and communication related to SRHR of indigenous women, girls, and gender diverse population who live with HIV. Incubate solution based on an informed culture regarding the sexual reproductive health rights of indigenous women, girls, and gender diverse population by developing appropriate tools made with solid global associations. Increase partnerships to inform sexual reproductive health rights programming, planning, and learning of care. Mentor and train indigenous women, girls, and the gender diverse indigenous populations with allied supporters in global sexual reproductive health rights metrics. Enhance the capacity of future indigenous or allied researchers, civil society, and in-country leaders to collect, analyze, communicate, and use data effectively. Develop the capacities of indigenous women, girls, and gender diverse population with the support of partner countries to develop global research on sexual reproductive health rights indicators, and support capacity building among indigenous people who identify as men and boys, including non-binary men, to be advocates and agents of change for the sexual reproductive health rights of indigenous women. Next, please. What are the products of this research? With the development of a core leadership team, this project will enhance the capacity of indigenous women and girls to participate at all levels of research while strengthening our indigenous and allied global alliances. A scoping literature review on sexual reproductive health rights specific to indigenous women, girls, and gender diverse population living with HIV will define the structure of the focus group discussions that will take place across the 7 partner countries. Capacity building groups discussions to increase opportunities for local indigenous women and anyone who self-identifies as a woman or girl to engage in research activities. These discussions will inform the development of a survey to be applied among stakeholders in the 7 participating countries. Findings from the focus group discussions will support the development of a survey of closed and open-ended questions. They will be validated and context-specific surveys on sexual reproductive health rights care from an indigenous perspective. The survey will be applied through the local projects team to partner indigenous women, girls, and gender diverse population living with or impacted by the HIV or other sexually transmitted and blood-borne infections. And finally, an indigenous appropriate toolkit on sexual reproductive health rights and its care for indigenous women, girls, and gender diverse population living with HIV will be created based on findings from the focus group discussions, surveys, and the scoping reviews. This toolkit will reflect the project's findings developed in each participating country, whose objectives is to support the improvement of sexual health and well-being of indigenous women locally and globally. Knowledge translation activities will draw on the toolkit to engage global and local stakeholders through collective actions in a specific context to support capacity building around sexual reproductive health rights by and for Indigenous women, girls, and gender diverse Indigenous population. This is in general the information of our project. Thank you.
Thank you, Patricia. I think that was thank you for giving us an introduction of this global research project and what is this project trying to achieve, and how this is going to respond to the needs of Indigenous community and how it's going to advance SRHR of Indigenous women, girls, and gender diverse communities. Thank you very much. And with I will invite, and thank you for sticking to the time also. We are well on time. And now I will invite Manjula Narsiman. So Manjula is an experienced public health scientist with an expertise in policy development evaluation. And she works with WHO. She leads WHO's work on self-care interventions for health and well-being and linkages between sexual and reproductive health and rights and HIV. So Manjula, please, floor is open to you and welcome.
Thank you so much.
You have
Thank
10
you,
minutes.
Sure, thank you. Hi everyone, and good afternoon, colleagues. I'm really pleased and honored to join you today for this webinar, and it has also been my honor to lead this work to the development of this guideline. So really pleased to be here. My intention here is to provide a very brief overview of the key principles behind the development of the consolidated guideline on SRHR of women living with HIV, which was published in 2017. And it is this guideline is the outcome of a broad consultative process. It involved really many national, regional, and global experts, including individuals and networks of people living with HIV that included representation from Indigenous women living with HIV. So the rationale and the scope of this guideline, and the reason we did it was because in many countries, the women living with HIV do not have equitable access to good quality health services, and they're also faced with multiple and intersecting forms of stigma and discrimination, which you have heard and you will probably hear more from our other colleagues. So in this presentation, I just want to give you just a quick overview of the guideline and just really to acknowledge that the focus of this guideline starts from the moment when the women already know that they're HIV positive. So this is when they know their status. So we acknowledge that they must first be reached by safe, voluntary, non-coercive HIV testing and counseling. And this guideline is really meant to help countries to more effectively and efficiently plan, develop, and monitor programs and services that monitor gender equality and human rights and be more acceptable and appropriate for women living with HIV. Next slide, please. So among the many leading roles of WHO is the mandate to develop high quality evidence-based guidelines to support countries and communities. So next slide, please. And very briefly, what we mean by a WHO guideline and a recommendation is noted here, and it really follows a very rigorous process. We look at whatever evidence is available, but we also hear from the voices of end users, and in this case, the voices of women living with HIV who informed this guideline process. Next slide, please. This guideline also consciously adopts the perspective of women, their families and communities, as I just mentioned, and it's grounded and advocates for a strengthened women-centered approach. Next slide, please. And some of the guiding principles are included here. And first and foremost, this guideline adopted an approach that is centered on the needs and rights of women, girls, and gender diverse individuals living with HIV. It sees them as active participants as well as beneficiaries of trusted health systems that can respond to their needs, to their rights, to their preferences in holistic ways. This guideline emphasizes the promotion of gender equality as central to the achievement of their SRHR. It requires that women are empowered through education and support to make and enact decisions in all aspects of their lives, including in relation to sexuality and reproduction. This guideline calls for strategies that promote women's participation in their own healthcare, and it recognizes the strengths of women living with HIV as active agents in relation to SRHR and not merely passive recipients of health services. And it is really, like as I said earlier, organized around their health needs and their priorities rather than a perspective of disease management and control. Next slide, please. Another unique principle, not unique, but key principle was the meaningful community engagement. And this was quite unique in the development of this guideline because we first started off with a global survey, which was conducted by and for women living with HIV to assess their priorities ahead of the expert working groups. And we received feedback from over 90 countries, women aged 15 to 72 years. And some of the key aspects of this report was to highlight the extent of violence, stigma, coercion, discrimination that women feel and face in not only in their communities, in their families, but also here in this context within the health facilities and systems. And also the resulting mental health concerns. So it highlighted a range of other things, but mainly the desperate need for quality, respectful care within health facilities and in the hands of health workers, which was lacking in particular for those who are most vulnerable, marginalized, or stigmatized. Next slide, please. And so the framework which was developed really shows that people-centered approach. And what we aimed to show with this framework is that we're placing the women at the center and the next slide, please. Including recommendations and interventions that support that enabling environment, which would be really important because you will see in the framework there was in blue were the health interventions, in purple the enabling environment, and both are going to be important because it's recognized that while policies, programs, interventions to improve SRHR of women, girls, and gender diverse individuals living with HIV, they may exist, but these alone will not bring about improved health outcomes in the absence of the safe and supportive enabling environment. Next slide, please. And you see this also for some of the good practice statements in addition to the recommendations that you will see. And you will notice that in each of these slides, there's a little house. And this is in line with the Global Values and Preferences Survey report, which I just mentioned earlier, which was led by and for women living with HIV. And this is to reflect that every recommendation in this guideline included the feedback from women living with HIV themselves, and every attempt was made so that the language used was respectful and aligned with their needs and rights as much as possible. Next slide, please. However, having a guideline alone is not going to be enough, and there are still far too many challenges that affect the health and well-being of women living with HIV. Next slide, please. And next slide is again. So the participatory approach used in the development of this guideline has led to the establishment of a WHO advisory group. Next slide, please. Next one. Next slide. Thank you. So as I was saying, the participatory approach we used in this guideline has led to the establishment of a WHO advisory group of women living with HIV, which includes representation of Indigenous women living with HIV. Next slide, please. And we recognize that there are many, many initiatives in countries. And so the effective implementation of this guideline really needs to be context specific and respond to the needs of the local context. Next slide, please. I just wanted to share these words from an Indigenous woman living with HIV who was involved in our guideline development, and it's really been, as I said, an honor to be working with these individuals and communities, because it's helped us strengthen the guidance and the tools that we have developed. But we still have a long way to go, and these webinars and the feedback that we receive, we hope to continue to strengthen the guidance that we provide from WHO. Next slide, please. So I'm sharing some resources here, but and these will be available on the chat and available to you afterwards. Please feel free to use them, but also to send us feedback, because this is a living guideline and we hope to continue to strengthen this. Next slide, please. So in conclusion, I really wanted to maybe state one thing, is that an integrated approach to health, to human rights, to gender equality really lies at the heart of ensuring the dignity and the well-being of women, girls, and gender diverse individuals living with HIV, including Indigenous people living with HIV. So I really look forward to your feedback on how best to implement this guideline, and also to overcome some of the barriers to service uptake, use, and continued engagement, to reduce stigma and violence, and to deliver the highest quality care possible. Thank you to everyone.
Thank you very much, Manjula. Thank you for giving us an overview of these guidelines. And I think it was great to know that how these were developed in a consultative manner, and how this process was led by women living with HIV, Indigenous women living with HIV/AIDS. I think that was wonderful to know, and it's a great document. And I really hope these guidelines really help in reducing the stigma and the discrimination against HIV. Thank you very much. And now we will invite our next speaker, GS Shiriniwas. So he is a public health professional with 2 decades of work experience. He has worked with various national, international, and multilateral agencies. He provides expertise and technical assistance to state and national government on HIV reductions program. And he is technical director with UWI.Tech India. And welcome, Shiriniwas, and over to you, and you have 15 minutes.
Thank you very much, Sanjita. Very good morning, good evening, good afternoon, whichever part of the world you are in, from me. And excellent discourses by speakers before me, and I'm sure I'm looking forward to the speakers after me. Just to set the record straight, ITech is not a tech company. It stands for International Training and Education Center for Health. It's basically a public health training and training unit, and it's housed in the University of Washington, Seattle. I work as a technical director in the India office, and we, because it's a part of the university, the training and education comes in, but we also implement programs across India on HIV, and are currently implementing a project that is funded by the Centers for Disease Control India and the northeastern India, especially Nagaland, Manipur, and Mizoram. And that's where our experience with indigenous population comes in, because normally when we talk about other parts of the country, we tend to forget the Northeast, which has a huge population of not just indigenous individuals, but also a lot of cross-border migration between India and Myanmar. So my discourse is going to be mainly on our experience and what has worked with us, what has worked for us while we work with both PLHIVs and with the indigenous population and the systems surrounding the population, and how we were able to in some way affect our results through certain tweaking of our policies. Next slide, please. So just to show you the sort of terrain that we work in, where we say that on normal days there is no road, and if it rains there is nothing. So on the right is one of our outreach workers who's trying to navigate a road that was a road just before the landslide, And this is the area which is very close to the Indo-Myanmar border, and it's in Nagaland. It's very close to the Indo-Myanmar border, with a high density of people injecting drugs and high density of people living with HIV. So you can imagine, if this is the situation, what sort of service provision can happen in this area, and how do people receive their daily medications or preventive harm reduction therapies if they have to not just help themselves, save themselves, but also ensure that there is no onward transmission. So this is just to show you the kind of terrain that we work in. Next slide, please. It's a little dull, but yeah, in the India map, for those who, and a lot of us are not very familiar with the northeastern part of the country. So this is where the yellow, green and brown blobs that you see are where these states are. And on the right of that is the entire country of Myanmar, and below that is the sea. So, you know, the pillars of our implementation work revolves around 5 major principles, in the center of which is gender. Because we just don't work with you know, men, women, but we work with all the genders, all 3 genders, and the transgender population being the most hidden in the northeastern part of the country, do receive a lot of are much more vulnerable than all the other genders involved. Equity remains one of the key principles with sustainability and stewardship, and our programs are driven by data. And this is just to tell you that what I'm going to talk about is data driven, it's evidence based and not anecdotal. Next slide, please. So as you see from my previous map, just to give you a brief introduction into the Northeast, you know, because of the porous borders and the political unrest in the other side of the country, there is a huge amount of migration. And what is very important is that each of these 3 states is as different as a country. While we have the plains and hills in Manipur, and communities of Maitis and the tribals in the hills, we have the Nagaland, which is divided into mainly the hilly areas, where there are strong tribal networks like the Wokhas, the Angamis, and each of them having their own individual leaders and individual groups. And Mizoram, which is a little more westernized, and which is closer to the border, but shares the ethnicity with the tribes across the border in Myanmar. So with this kind of a population, and with a porous border with quite frequent flow of opioids, especially heroin, to and from to India, obviously the possibility and the prevalence of injecting drugs is huge. While that happens, the inaccessibility to services and the very difficult terrain makes it even more difficult for any kind of interventions to reach these areas. So what has worked for us, and these are the recommendations that we have from our side to the policymakers to consider while they're drafting the guidelines or implementing it, is one of the first things that worked for us was the push versus the pull factor that helps people come into health system. Any public health program, mainly in, if we see, you know, tends to push people into a health system. They ask people to go to a place to get themselves tested, to go get themselves treated. And you know, one of the best examples I feel as a public health specialist, I feel that COVID, despite all the pains that we have faced, has shown us what works in public health. The pull factor, which made it easier for people to register themselves for vaccination, which made it easier for people to go and seek services, is what is attractive for people. So while we design guidelines and implement them, we need to ensure that the people find it attractive enough to get to a place, and that happens only when we have a system which is equitable, which is non-judgmental, and which is totally free of any bias. Some examples from our end has been that, while I was talking about the third gender, the transgender, and the women population, we realized that the women who were injecting drugs did not have a safe space to go to. While the program, the system was pushing them into these systems where existent dominant male population went, this particular group of women and transgenders, women who inject drugs and transgenders, were finding it difficult to reach there. And just by addition of specific facilities which cater to this population, we were able to turn around things and register a lot more hidden female injectors. And that showed the policymakers that yes, that a little bit of tweaking, a little bit of adjustments go a long way in reaching out to the maximum number of people. The other thing is the focus on youth, mostly unrecognized and unappreciated group of people. And we realize that, especially speaking of indigenous populations, they play a huge role in the policies that govern the other peers in a village. And reaching the young youth associations, reaching the tribal associations or the chief of the tribal association, and building bridges with the youth groups goes a long way if we need to take services to them. So while I was talking about push versus pull, I also would like to focus on the youth to ensure that services are taken to the people rather than asking people to come to the services. Because just to quote an example, in some of the districts in the in Nagaland, up in the hills, it takes them nearly 3 hours, 3 days of walking. So it includes walking in the morning, rest for some time in the afternoon, then walking night, sleep on the roadside, next day morning walk again. And I'm not exaggerating, it takes them 3 days to reach a district hospital, pick up their pills, and or get themselves screened and go back to their village. 3 more days to go back to their village. So apart from the physical hassle, it's also loss of 6 days wages. So taking services to them, as a result of that, we motivated the government to buy motorcycles and started an outreach through motorbike in that terrain. There is a special kind of motorbike that is available only for that terrain, and that is helping us take services to the people. The third very important part that I would like to ask the policymakers to include is the inclusion of faith-based organizations when we are talking about systems within the indigenous population. We realized a few years back that we were working with men, we were working with women, we were working with transgenders, youth, but people were just not turning up at the facilities or were not accepting the services that were being offered until and unless the local pastor, the local church leader spoke about it through his sermons, his or her sermons. So, while systems, and, I know most of you would appreciate that the empowerment of women is, I consider, a little higher in the northeastern part of the country than in some of the parts of the country. However, despite all the balances that we were trying to get into place, we were unable to break that barrier, which a faith-based organization or a church leader could do. And I understand that the Northeast is, a very strong church leaders there. And that is something that helped us a lot, and I'm sure would be helpful for other indigenous population. The fourth thing was strengthening the outreach to reach the hard to reach populations. And most of these villages or groups that we were reaching out to lived across hills. So although we would talk about a few kilometers, it would take hours to reach that, not just because of the road, but because of the terrain. The fifth was, our experience was on the comprehensiveness of an approach. Whether you want to provide a service that is related only to HIV or make it more comprehensive so that a person who's coming would not only receive services for one illness, because at the end of the day, the person is one. but would also be able to receive a lot of other benefits. And that is one of the key factors that attracts people to a service point. And finally, a very important approach that we realized was of a family-centered approach, where, like the speaker from WHO, Manjula, was talking before me, that once a woman turns positive, or a man turns positive, or a child turns positive, the entire, or any illness, not just HIV, for any illness, the entire family gets affected. And we've seen that as recent as a few months back in COVID, the entire family gets affected, and unless and until the entire family is treated. So we had examples where the parents would be coming in, the mother would be coming in for her pill pickup on a certain day, the father would be coming on another day, and the child would have a third day for which one of the parents had to come. And it needed a lot of effort to ensure that the dosage and the times were evened out so that the entire family could come together for an assessment once every 3 or 6 months, and at least one person from the family could come and pick up pills for all of the people. And for us, especially in areas where even reaching the next village takes many hours, we found that these solutions of attraction, of focusing on the youth, of engaging the faith-based organizations and strengthening outreach through a comprehensive approach, and treating the entire family was something that we found was very helpful. And in the limited time that I have, would urge the policymakers to include these while implementing the programs for indigenous population. And before I end, just one last slide from my side, which is to conclude. Next slide, please. Which is to conclude that no amount of, I cannot stress on the fact that inclusion of faith-based organizations, especially in areas which have strong presence of faith-based organizations, goes a long way in ensuring that the services are appropriately provided, and services reach the population. Treating the entire family and not just one person, be it the mother, father, or the child, again is extremely important. And as has been the practice and example that has been set by the WHO all throughout their journey from the beginning, the engagement of the entire community, and seeking support from the community and ensuring that the community voices are heard. And when I'm talking about the community, I'm not just talking about the community of people living with HIV, but the entire village. So if you're talking about a village, the entire village voices of all the people are, unless and until they're heard and addressed, it will not make a difference to that one person who needs the change. So as of now, that's all from me, but I'm there for any questions, and I hope I have stuck to my time limit. Thank you, Sanjit.
Thank you, Shiriniwas. Yes, you were well on your time. You did not need any reminder. I'll say that none of the speakers, none of the presenters needed any reminder for the time. Yeah, thank you for sticking to the time, and thank you for sharing those wonderful insights from your work in Northeast. And totally agree, Northeast is a very difficult terrain to work, and how issues of Northeast are not known to the entire country, how it's treated like a very separate, those are considered very separate issues and not mainstream issues. And also I completely agree that the underlying determinant of political instability, adding more layers, like how it makes any interventions very difficult. And also thanks for sharing what works in Northeast from your experiences. I think it was really wonderful to listen to you. Thank you very much, Shiriniwas. Thank you.
Thank you.
And all request to all the participants, they can put their questions in the chat box. And now I will invite our next speaker, Muni Kumari. So Muni will share her experience of living with HIV and her experience of working with the tribal community in Jharkhand. So Muni is an activist, and she's an activist, and she's working against the stigma associated with HIV. Through counseling, she helps many women to get proper medical treatment, and she also provides provides them psychosocial support. So she has lived experience of HIV and other experiences of vulnerability tribal women with HIV face in their lives. She is associated with Jwala Shakti Samuh, a grassroots organization in Jharkhand, which works with the rights of women of marginalized community and women working as sex workers. Muni, please, can you please switch on your camera in case you would want to? Muni and Pushpa, आप camera switch on करना चाहेंगे? Yeah. And Muni will speak in Hindi, but all the presentations, her slides are in English. So in the end of our presentation, I'll provide a quick summary. I'll translate them into English. Thank you. मुनी आप तैयार हैं? हेलो मुनी, आप सुन पा रहे हैं? हेलो मुनी, आप सुन पा रहे हैं? पुष्पा, आप सुन पा रहे हैं?
हाँ मैम।
ओके ओके, प्लीज आप शुरू कर दीजिए पुष्पा
जी।
ओके, थैंक यू।
सभी को जोहार। मेरा नाम पुष्पा है और मैं झारखंड से हूँ और ज्वाला शक्ति समूह एक सेक्स वर्कर का समूह है जिसको मैं हैंड होल्डिंग सपोर्ट करती हूँ। और हमारे साथ मुन्नी है जो एक HIV पॉजिटिव पेशेंट है। चूंकि मुन्नी उनको थोड़ा सा तबीयत खराब है उनके फेस पे, तो वो बोल नहीं पा रही हैं, तो उनके बिहाफ में मैं प्रेजेंट करूंगी। तो मैं झारखंड की पृष्ठभूमि थोड़ा बताना चाहूंगी हम इसमें आगे जाने से पहले। नेक्स्ट स्लाइड प्लीज। झारखंड एक आदिवासी बहुल क्षेत्र है। यहाँ की जनसंख्या है 8,645,000 यहाँ की जनसंख्या है। ये आंकड़ा हमने लिया है सेंसस से 2011 में जब जनगणना हुआ था, उस समय का ये आंकड़ा है। झारखंड एक नक्सली प्रभावी क्षेत्र है। यहाँ पे नक्सल का प्रकोप ज्यादा है, गरीबी और अशिक्षा ज्यादा है। आजीविका यहाँ का जो है वो कृषि के ऊपर निर्भर करता है और कृषि जो है वो मानसून के ऊपर निर्भर करता है। चूंकि यहाँ पे पिछले कई वर्षों से पानी की बहुत दिक्कतें हो रही थी, मानसून उतने अच्छे से नहीं हो रहे थे, तो लोग काम के लिए पलायन ज्यादा करते हैं। और ये इनके शुरू से ही है झारखंड में, आज ये नया नहीं है, पहले से भी है, पूर्वजों काल से ही यहाँ पे पलायन ज्यादा होता है। यहाँ पे महिला और किशोरियों का पलायन ज्यादा होता है। पुरुष प्रधान गांव है, क्षेत्र है, जिस वजह से महिलाओं को थोड़ा कम अवसर मिलते हैं। और यहाँ की महिलाएं काफी सशक्त होती हैं। ट्राइबल महिलाओं को बहुत सारा फ्रीडम है, उनको अपने पार्टनर चुनने का फ्रीडम है, उनको मोबिलिटी का फ्रीडम है। तो इसलिए घर का जो पूरा निर्णय होता है एज ए मुखिया बोले तो वो यहाँ की महिलाएं ही होती हैं। लेकिन फिर भी इसके बावजूद भी पुरुषों का दबदबा थोड़ा ज्यादा है यहाँ पे। सरकारी योजना और जो उनकी प्रक्रिया है उसके बारे में यहाँ की महिलाओं को बहुत कम जानकारी है। चूंकि ये घर और बच्चे के पीछे ज्यादा व्यस्त रहते हैं, तो इनको उस तरह के मौका नहीं मिलता है बाकी ये इन सब चीजों पे ज्यादा ध्यान दें, और जानकारी उनको कहीं से उपलब्ध नहीं हो पाता है। समुदाय में विभिन्न प्रकार की हिंसा देखने को मिलता है, भेदभाव, लिंग डिस्क्रिमिनेशन होता है। उसके बाद घरेलू हिंसा, डोमेस्टिक वायलेंस, ट्रैफिकिंग, सेक्सुअल एक्सप्लॉयटेशन, चाइल्ड मैरिजेस, चाइल्ड ट्रैफिकिंग, ये सारे मुद्दे यहाँ पे बहुत ज्यादा आपको देखने को मिलेगा। नेक्स्ट स्लाइड प्लीज। जब हम लोग यहाँ पे 2007 से यहाँ पे जब हम लोग सेक्स वर्कर्स के साथ में काम कर रहे थे, तो उनके साथ जब हम बातचीत करते थे और चर्चा करते थे, तो लगातार उनके साथ में एक्सप्लॉयटेशन की जो बात है वो निकल के आता था कि हमें आज पुलिस वाले ने मारा, आज हमें किसी क्लाइंट ने मारा, उन्होंने पैसा नहीं दिया, हमें कोई घर वालों ने देख लिया तो मुझे घर से निकाल दिया, घर में बहुत मारपीट हुआ। तो इस तरह की चीजें निकल के आती थी, तो बहुत हम लोगों को चिंता होती थी कि हम लोग इन महिलाओं को कैसे सपोर्ट कर सकते हैं। तो फिर हम लोगों ने एक कमेटी का निर्माण किया जिसका नाम ज्वाला शक्ति समूह है। और ये समूह तो हम लोगों ने बना लिया था, पर इसको हम लोग सशक्त करने या इसको एज ए राइट्स के रूप में कैसे देखेंगे, इसके ऊपर में हम लोग को बहुत चिंता हो रही थी, हम लोग नहीं समझ पा रहे थे। तो नेशनल नेटवर्क ऑफ सेक्स वर्कर जो सांगली में है और जो वहां से हम लोगों ने उनके साथ में मिल जुड़ करके हम लोगों ने काफी इसके ऊपर ट्रेनिंग और एक्सपोजर विजिट किया। आरती मैम और जो मीना शिशु है उन्होंने काफी हम लोगों को ट्रेनिंग प्रोवाइड कराई और हम लोगों को सेक्स वर्कर राइट्स के बारे में बहुत बताया। तो फिर हम लोग झारखंड में आके इसको और विस्तृत रूप से काम किया। यहाँ पे बोर्ड समूह जो ज्वाला शक्ति समूह का बोर्ड मेंबर है उसमें कुल 11 सदस्य हैं और 160 सदस्य ऐसे हैं जो अलग अलग जिलों से हैं और इनके मेंबर्स के रूप में हम लोग इनको जोड़ पाए हैं। जेएसएस झारखंड के 5 जिलों में काम करती है। जेएसएस के द्वारा रांची और गुमला में सघन रूप से काम होता है, क्योंकि यहाँ पे 2 जगह हेल्प डेस्क बनाया है हमने और उस हेल्प डेस्क के माध्यम से हम लोगों ने सेक्स वर्कर का स्टडी किया है, करीबन 600 सेक्स वर्कर का, और उनका डॉक्यूमेंट्स बनाने में उनको सपोर्ट किया है। सेक्स वर्कर का ट्रेनिंग देकर उनका क्षमता विकास करने का कोशिश किया है और जो भी सेक्स वर्कर्स के केस आते हैं वो ज्वाला शक्ति समूह के सदस्य हैं जो उनको सपोर्ट करते हैं इसके ऊपर, चाहे वो क्लाइंट का हो, पुलिस का हो या उनके पर्सनल घर के मामले हो। नेक्स्ट प्लीज। अगर हम झारखंड में हम 2 तरीके से बात करेंगे। एक तो हम झारखंड में आम महिलाओं और आम समुदाय जो आदिवासी समुदाय है उनको लेकर भी बात करेंगे और इनके साथ ही हम सेक्स वर्कर और जो HIV पॉजिटिव पेशेंट है उनके बारे में भी बात करेंगे। तो झारखंड में अगर हम देखें तो समस्या के रूप में तो इनको स्वास्थ्य सुविधाओं तक पहुंच कम होता है, इनको जानकारी और सूचना का अभाव होता है, समुदाय द्वारा जो भेदभाव डिस्क्रिमिनेशन है वो काफी होता है। यहाँ बहुत दूर दराज गांव में लोग रहते हैं तो वहां से उनको अस्पताल जाने की दूरी बहुत होती है, वहां तक पहुंच नहीं पाते हैं, पक्की सड़क नहीं होती है, कोई यातायात के साधन नहीं होता है उनको, और बहुत गरीबी होने के कारण अगर वो जाना भी चाहते हैं तो उनके पास पैसे नहीं होते हैं कि वो भाड़ा दे करके वहां तक जा करके सेंटर में अपना इलाज करवा ले। अगर मान लीजिए किसी तरह से एक बार वो इलाज करा भी लिए तो दोबारा फिर उनको जाना और बार बार जाना उनके लिए बहुत मुश्किल होता है, तो वो नहीं जा पाते हैं और इस तरह से हेल्थ जो सिस्टम और सुविधा है उनसे काफी उनका दूरी और ये कटे हुए रहते हैं। नेक्स्ट प्लीज। HIV पॉजिटिव महिलाओं को देखे जो ST आदिवासी समुदाय में हैं तो उनके जो मेजर प्रॉब्लम्स जो आते हैं वो है उनका SRHR से संबंधित मासिक धर्म स्वच्छता, जो मेंस्ट्रुअल हाइजीन की बात होती है, HIV की जो जांच वगैरह होता है उनको लेके उनको दिक्कत होता है, मानसिक मेंटल हेल्थ के ऊपर में उनको प्रॉब्लम्स होता है, उनकी सेक्सुअलिटी को लेकर के बहुत सवाल खड़े होते हैं, उस पर उनको ज्यादा प्रॉब्लम होता है। फिर उसके अलावा जो गैर संचारी रोग है जो नॉन कम्युनिकेबल डिजीज है उसके ऊपर में भी उनको प्रॉब्लम होता है और कम्युनिटी का सपोर्ट उनको बहुत कम होता है, चाहे वो आम कम्युनिटी हो या फिर वो सेक्स वर्कर कम्युनिटी हो उसमें। नेक्स्ट प्लीज। HIV की जो पॉजिटिव महिलाएं हैं उनके साथ में जो बातचीत करके हम समझ में आया था मुझको, वो मैं यहाँ पे लिखी हूँ कि HIV जांच अभी हमारे यहाँ पे सारे झारखंड के सारे अस्पतालों में है, वो टेस्ट करके ये बता सकते हैं कि पॉजिटिव है, लेकिन उनका आगे का जो ट्रीटमेंट होता है उसके लिए उनको जिला अस्पताल में आना पड़ता है। और हमारे झारखंड के जो 24 जिले हैं उनमें से केवल 8 जिलों में ही ART सेंटर है जहाँ पे हम लोग ART का टेस्ट और वायरल लोड का टेस्ट और जो ART जो दवाई है वहां से ले सकते हैं। उसके बाद जब ART एक बार लिंकेजेस हो जाता है तो एक ART के लिए हम लोग अपने जिला के जो अस्पताल है वहां पे ले सकते हैं, लेकिन फिर जब उनको वायरल टेस्ट कराना पड़ता है तो उनको वायरल लोड का टेस्ट कराने के लिए फिर उनको जिला आना पड़ता है। तो ये बहुत उनके लिए बहुत भागा दौड़ी वाला और बहुत मुश्किल वाला काम होता है। अस्पताल की दूरी इतना ज्यादा है, जहाँ पे हम वायरल लोड की बात करते हैं वो इतना ज्यादा दूर पे है, जैसे मान लीजिए कि अगर गुमला की कोई महिला है या फिर वेस्ट सिंहभूम की कोई महिला है तो उनको रांची आने के लिए उनके पास में पूरा रात का सफर करना पड़ता है या तो 3 से 4 घंटे का सफर करना पड़ता है और पैसा भी बहुत ज्यादा लगता है। तो इस वजह से कभी कभी उनका HIV का जो दवा है वो पैसा कम होने की वजह से बीच में ही छूट जाता है और फिर उनका वायरल लोड और ज्यादा बढ़ जाता है और खतरा उनके लिए काफी हो जाता है। उनको जानकारी का अभाव होता है क्योंकि वो HIV पॉजिटिव पेशेंट है और उनका बार बार काउंसलिंग का जो ये चीज है वो कम होता है, उनका नहीं प्रोवाइड हो पाता है, या वो उन सुविधाओं तक नहीं पहुंच पाते हैं, जिस वजह से उनको प्रॉपर ये नहीं बताया जा पाता है, या वो नहीं समझ पाते हैं कि उनको इस दौरान कैसे खाना चाहिए, क्या कैसे रहना चाहिए, उनका सेक्सुअल रिलेशन बनाने समय उनको किन किन प्रिकॉशन को लेना चाहिए। ये सारी चीजें उनको बहुत मुश्किल से मिलती है, या फिर अगर छोटी छोटी बीमारियां उनको हो जाती है जैसे फीवर, सर्दी, खांसी या कोई और प्रॉब्लम्स हो जाता है, तो उसको इलाज कराने के लिए उनको फिर से उतना दूर जाना पड़ेगा, तो वो इलाज वो नहीं करवा पाते हैं और इसी कारण से तो उनका डेथ भी होने का संभावना होता है। दूसरा एक चीज है कि यहाँ पे महिलाएं चूंकि जानकारी का अभाव है और वो अपने हेल्थ को उतना प्राथमिकता नहीं देते हैं, उनके लिए सबसे प्राथमिक होता है उनका घर, उनका बच्चा और उनका पति, तो वो उनके ऊपर में ज्यादा ध्यान देते हैं और अपने स्वास्थ्य के ऊपर में बहुत कम ध्यान देते हैं। तो वो प्राथमिकता न देने की वजह से भी उनको प्रॉब्लम्स बहुत झेलना पड़ता है। सेक्स वर्कर की बात जब हम करते हैं और वो HIV पॉजिटिव होते हैं, तो वो और भी नहीं जाना चाहते हैं क्योंकि उनकी जो गोपनीयता है वो भंग होगी। अगर उनकी प्राइवेसी लीक हो गई, लोगों को पता चल गया कि वो सेक्स वर्कर, और उनको वो रांची में जाती हैं ये बोल करके कि झूठ बोल के कि हम वहां काम करने जा रहे हैं, और फिर वहां पे जाकर वो सेक्स वर्क करती है, ये अगर उनको पता चल गया तो उनको गांव से भी निकाल देंगे, सोसाइटी से निकाल देंगे, समाज तो और परिवार तो उनको एक्सेप्ट करेंगे ही नहीं, तो फिर उस महिला के लिए कुछ भी नहीं बचता है और वो महिला बहुत परेशान हो जाती है। उनके लिए कोई ऐसा जगह नहीं होता है जहाँ पे वो जा करके अपना जीवन यापन कर सकती है, तो वो इसलिए भी अपना ट्रीटमेंट कराने में थोड़ा हिचकिचाती हैं और वहां पे जाना नहीं चाहती हैं। नेक्स्ट प्लीज। SRHR के मामले में अगर हम बोले तो महिलाओं को गर्भ धारण करने पर अधिकार नहीं। यहाँ की जो ट्राइबल महिलाएं हैं उनका जो गर्भ धारण प्रेगनेंसी का जो राइट्स होता है कि एक महिला अगर चाहे तो कितना बच्चा ले सकती है, ये राइट्स उनके पास नहीं है क्योंकि उनका पर्सनल लॉ उनको प्रॉपर्टी राइट्स नहीं देता है, और जब प्रॉपर्टी राइट्स नहीं मिलता है तो फिर वो उनको ये कहा जाता है कि जब तक तुम्हारा बेटा नहीं होगा तब तक तुमको संपत्ति में हिस्सा नहीं मिलेगा। तो वो बेटा पैदा करने के चक्कर में वो और भी ज्यादा बच्चा पैदा कर लेते हैं, उनकी लड़कियां ज्यादा हो जाती हैं और फिर वो उनको संभाल नहीं पाती हैं, फिर उनका कमजोर हो जाता है शरीर और फिर वो कुछ भी नहीं कर पाती हैं। तो ये राइट्स उनको कभी भी नहीं है। अगर उनको बेटा नहीं हुआ है तो 7-8 बेटी होगा तो भी चलेगा, कोई दिक्कत नहीं है, पर जब तक बेटा नहीं होगा तब तक उनको बच्चा पैदा करना ही पड़ेगा। ये एक बहुत बड़ा मतलब उनके अधिकार का हनन है। अगर HIV पॉजिटिव कोई महिला है तो जब वो अस्पताल में जाते हैं या कोई भी उनको अगर कोई काउंसलिंग करता है तो उनका जो सबसे पहला जो बात होता है वो ये कहते हैं कि आप प्रेग्नेंट मत होना, आप बच्चा पैदा मत करना। उनको कभी भी ये पॉजिटिवली सलाह नहीं दिया जाता है कि आप बच्चा पैदा कर सकते हो या आपको PPTCT सेंटर है, आप वहां पे जाके इलाज कर सकते हो। इस तरह का जो प्रॉब्लम्स जो फैसिलिटीज है वो फैसिलिटीज को उनको बताया नहीं जाता है, उनको बस एक इस तरह से काउंसलिंग किया जाता है जिससे कि वो और डर जाती हैं 2-3 चीजों से। एक तो अपने हेल्थ के ऊपर वो डरी रहती हैं कि अब हमको HIV हो गया तो अब हमको मरना ही पड़ेगा। दूसरा, अब हम बच्चा नहीं होगा तो घर वाले क्या कहेंगे, फिर मेरा तो कोई अस्तित्व ही नहीं रहेगा। तीसरा, उनको ये डर रहता है कि मैं चूंकि सेक्स वर्कर हूँ और मुझे इस कारण से हुआ है, तो वो कारण अगर किसी को पता चल जाता है तो उसको पूरा प्रॉपर्टी और समुदाय से दूर कर दिया जाता है। तो ये सारी चीजें उनको बहुत डिमोटिवेट करती है और वो फिर इलाज कराने के लिए वो जाना नहीं चाहती है। स्वास्थ्य से संबंधित जानकारी बहुत कम होता है। छोटा छोटा सा भी जानकारी, अगर सर्दी खांसी बुखार भी उनको हुआ है तो उसके लिए उनको ये नहीं पता है कि उनको कहाँ जाएंगे तो हमको फ्री में दवा और फ्री में ट्रीटमेंट मिलेगा। गांव में बेहतर स्वास्थ्य संबंधित सेवा उपलब्ध नहीं है, छोटा मोटा हॉस्पिटल है, चीजें है, पर उतना अच्छा सेवा उपलब्ध नहीं है जहाँ पे उनको बेहतर सेवा मिल सके। नियमित जांच और उपचार, जो चूंकि HIV पॉजिटिव है तो गांव में मिलेगा नहीं, जिला वो जा नहीं सकते, स्टेट में उनकी जाने की औकात नहीं है, तो इस समय में उनको बेहतर उपचार और जांच नहीं मिलता है, ना नियमित वो करवा पाती है। प्रखंड और जिला के जो अस्पताल है वहां पे अगर कोई पॉजिटिव पेशेंट पता चलता है, वो प्रेग्नेंट है, तो जब वो प्रसव के लिए जाती है तो वो लोग काफी हिचकिचाते हैं, वो उनको डिलीवरी करने को तैयार नहीं होते हैं। वो एकदम नहीं चाहते हैं कि पॉजिटिव पेशेंट का डिलीवरी हम लोग करें। पीपीटीसीटी सेंटर तक पहुंचने में समस्या होता है उनको, तो ये वजह होता है कि उनका डिलीवरी घर में ही हो जाता है कभी कभी। जिला लेता नहीं है, राज्य तक वो पहुंच नहीं पाते हैं, तो उनका जो ये डिलीवरी है वो घर के अंदर ही हो जाता है। और जब उनको ये पता होता है महिला को कि हम HIV पॉजिटिव है और जिला हमको लेगा नहीं, तो वो जब प्रेगनेंसी लेबर पेन उनको शुरू होता है तो वो वहां जाना भी नहीं चाहते हैं, वो घर में ही डिलीवरी करवा लेना चाहते हैं, जो कि बहुत ही अनसेफ होता है। प्रजनन और यौन संबंधित जो सेवाएं हैं, जैसे मान लीजिए मामूली से अगर उनको वाइट डिस्चार्ज हो रहा है, या उनके विजाइना में जलन हो रहा है, या उनको खुजली हुआ है, या किसी भी तरह का इस तरह का प्रॉब्लम होता है, तो वो इस बात को बोलने से शर्माते हैं। उनकी बातों को लोग मतलब अगर कोई महिला कह भी रही है कि मुझे मेरे विजाइना में इन्फेक्शन हुआ है, तो उनका तुरंत का ये रिएक्शन होता है कि किसी और के पास गई थी क्या तुम, या तुम किसी और के साथ संबंध है क्या तेरा। वो उनका पति या उनका परिवार ये मानने को तैयार ही नहीं होता है कि ये इन्फेक्शन उनके पति से भी आ सकता है या उनके पार्टनर से भी आ सकता है। वो हमेशा औरतों के कैरेक्टर के ऊपर ही उंगली उठाते हैं कि तुमको ये इन्फेक्शन किसी और के साथ में रिलेशन बनाने से हुआ है। तो ये भी महिलाओं को काफी डिमोटिवेट करती है। नेक्स्ट, मेंस्ट्रुअल हाइजीन की जब हम बात करते हैं, तो एक तो मेंस्ट्रुअल हाइजीन की जो जानकारी है वो काफी कम है। हम ये जानते हैं कि महिलाओं को जब भी उनकी पीरियड्स होते हैं या उनसे संबंधित कोई बात होता है, तो हमेशा इसको शर्म की दृष्टि से देखा जाता है और लोग बोलते हैं इसको बताना मत, इसको छुपा के रखना। यदि वो कपड़ा यूज करते हैं, गाँव में महिलाएं अधिकतर कपड़ा यूज करती है, अगर वो कपड़ा यूज करते हैं तो उसको भी वो धो करके धूप में नहीं सुखा सकते हैं ताकि उसके अंदर की जो बैक्टीरिया है वो मर जाए। वो उनको घर में कहीं छायादार छुपा के, बेड के नीचे, दरवाजे के पीछे, ऐसी जगहों पे उनको सुखाते हैं और इससे इन्फेक्शन उनका ज्यादा फैलता है। जब उनका पीरियड खत्म हो जाता है, वो कपड़ा को धोते हैं और धो करके फिर वो किसी ऐसी जगह पे रखते हैं जहाँ पे जैसे छान में खोस के रख दिए, छप्पर में लगा के रख दिए, तो इन सब जगह में उनके अंदर में छोटे छोटे कीड़े वगैरह अगर कुछ घुस गए, फिर नेक्स्ट बार वो उसी कपड़े को यूज करते हैं। तो ये काफी अनसेफ है, जो हाइजीन है, जो उनको दिक्कत होता है करने में। जागरूकता की कमी है, कोई इसके ऊपर चर्चा नहीं करता है, तो उनको कोई ये बताता भी नहीं है कि मेंस्ट्रुअल साइकिल के समय में आपको कैसे साफ सफाई का ध्यान रखना है, कैसे आप कपड़े को धूप में सुखाएंगे, आपको पैड लेना चाहिए, कपड़ा यूज करते हैं तो उसको कैसे, उसका रख रखाव कैसा होगा, उसका निपटारा कैसा होगा। ये सारी चीजें बताने के लिए कोई प्रशिक्षित लोग नहीं होते हैं, और अगर होते भी हैं तो उनके साथ में महिलाएं कंफर्टेबल नहीं होती है बात करने के लिए। मेंस्ट्रुअल हाइजीन की मुद्दा जो है, अगर महिलाएं इसको बोलती भी हैं तो इसको प्राथमिकता नहीं दी जाती है। उनको अगर बोलना भी है तो कहते हैं ये सब फालतू बात है, इसको मत बोलो, ये सब ऐसा बात है, ये औरत का बात है, औरत लोग ही समझेगी। पुरुष इसको सुनना भी नहीं चाहते हैं, और अगर सास वास है या उनकी माँ है तो वो लोग उनको झांक उक और रख देते हैं कि ये सब बात बाहरी लोगों को मत बताओ, बहुत दिक्कत होता है। और जो गांव का दवा है, जो ग्रामीण गांव में कुछ जड़ी बूटी वाला दवा होता है, वो सारे दवा इस्तेमाल करने की सलाह देते हैं। इससे
आपके पास 2 मिनट है, आपको रैप अप करना होगा।
ओके 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 ओके। इसके अलावा मासिक धर्म की जो पारंपरिक जो अवधारणा है वो भी महिलाओं को प्रॉब्लम करता है। नेक्स्ट प्लीज। HIV पॉजिटिव महिलाएं की जब हम उनकी यौनिकता की बात करते हैं, तो जब उनकी जानकारी किसी को हो जाता है तो उनको क्लाइंट मिलना मुश्किल होता है। क्लाइंट के साथ कंडोम का इस्तेमाल करने में काफी चैलेंजेस यूज करना पड़ता है, ये बताना नहीं चाहती है, क्लाइंट को पता नहीं होता है, तो बिना कंडोम का सेक्स करते हैं और ये HIV फैलने का भय होता है। उसके बाद पेशेंट को खुद भी डर होता है कि पता नहीं उनको पॉजिटिव है या हम पॉजिटिव है, तो एक दूसरे को फैल सकता है। ज्यादा क्लाइंट नहीं ले पाते हैं, चूंकि वो कमजोर होते हैं तो थक जाते हैं, तो वो ज्यादा क्लाइंट नहीं ले पाते हैं। और जो पीएम एजेंट होते हैं वो उनको सपोर्ट नहीं करते हैं क्लाइंट से डील कराने में या क्लाइंट देने में। नेक्स्ट, मानसिक स्वास्थ्य की बात करते हैं तो हमारे यहाँ पे जो जिला गांव में अस्पताल है या जिला में जो अस्पताल है वहाँ पे मेंटल हेल्थ के लिए कोई डॉक्टर अवेलेबल नहीं है, अगर है भी तो वो सप्ताह में एक बार आते हैं, जिससे कि लोग नहीं उनसे मिल नहीं पाते हैं। और रिम्स में पहुंचना उनके लिए नामुमकिन है, ये हमने पहले ही बताया है कि उनके पास में वो सुविधाएं नहीं होती है। काउंसलिंग की व्यवस्था जिला में नहीं होती है, और उनका ये इंफॉर्मेशन भी लोगों को बहुत काफी नहीं होता है। नेक्स्ट प्लीज। अगर समुदाय की हेल्प की बात करते हैं तो अगर पॉजिटिव पेशेंट के बारे में पता चलता है या किसी भी आदिवासी महिलाओं को पता चलता है कि ये पॉजिटिव पेशेंट है, तो सबसे पहले उनको कैरेक्टर में सवाल उठाया जाता है। उनको जो उनका फैमिली है उसको एक्सेप्ट नहीं करते हैं, उनको समुदाय से बहिष्कार किया जाता है, उनको शारीरिक, मानसिक और आर्थिक रूप से काफी कमजोर हो जाती है वो, क्योंकि उनके पास में वो पैसा भी नहीं होता है कि वो इलाज करा पाए और उनको बेहतर काउंसलिंग नहीं मिलता है, तो ना ही किसी को बता पाती है, ना ही अपने अंदर रख पाती है। तो ये मेंटली बहुत टॉर्चर होती है और ये बात वो किसी को नहीं बोल पाती है, तो अंदर ही अंदर घुटते रहती हैं और डिप्रेशन में चली जाती है। मैंने 2-3 महिलाओं को ऐसा भी देखा है जिन्होंने सुसाइड तक किया है अगर वो पॉजिटिव है तो ये प्रॉब्लम्स हमारे यहाँ पे हैं। अगर आपको कोई क्वेश्चन है, मेरा खत्म हो गया, थैंक यू। अगर कोई क्वेश्चंस वगैरह या कुछ और है तो प्लीज मैम। हेलो
Thank you Pushpa, thank you so much. I think that was like really great presentation. I'll translate what Pushpa shared. Since the speaker was Muni, but she couldn't speak because her face was swollen, so she requested Pushpa to speak on her behalf. So Muni is a person who's living with HIV, and she works with one organization, Jwala Shakti, which is a group of organization of a sex workers, and Pushpa also works with this organization, and they share their experiences of working with the community and living with HIV. So they come from a state called state Jharkhand, which is predominantly a tribal state. And she talked about poor health and overall human development indices of the state, and it is a male dominated society. And she again talked about that how being a sex worker from the tribal community, in addition to the discrimination, they face domestic violence, they face violence from clients, they face violence from police, they face violence from local goons. And the overall is in a community, they lack access to information, they don't have access to any government information, to any government schemes, and access to health services. Then again, she talked about the lack of transport services in accessing health services, I think, which was in similar to what Shiriniwas talked about in Northeast. There, like, it takes 3 days in Northeast to get any services, to reach to any center and to go back to their respective places. And similarly, Pushpa also talked about how transport is a big barrier in accessing those health services, and which makes them more vulnerable. And then she talked about, then there is a breach of privacy. If why they are hesitant of all, even if they have crossed all the barriers and reached to the health center, and if there is a disclosure of their identity, and which they wouldn't want to, they would want to maintain their privacy, and which, like, makes them hesitant to visit the health centers. And in terms of sexually and reproductive health issues, Pushpa talked about menstrual hygiene, like there is no awareness about it, and how unsafe methods they are using it, and how they do not have a right to their own pregnancy, how they insist, like, within there is a practice that they would want to have a more son, so they would keep producing more and more number of children until they have a boy. So this is how they said that this is a violation of their right to have a pregnancy. And then she again talked about the HIV testing and the treatment, and then the mental health. They don't get, like, there is no mental health facility available to their vicinity. And she talked about how 1 or 2 women in the community, I mean, like, when they were of a positive status and they committed suicide, they died by suicide. And then again she talked about the sexual health issues. If their identity is known, then it's very difficult to get them the clients, and then they lack the community support. Community does not support them. And then again she talked about the white discharge also, which is a very simple problem, but they do not get the treatment because how their partners see them. The white discharge is seen as, like, it's a sign of having an affair with other men, so it discourages them to seek treatment. So thank you Pushpa. And if you have any questions, you can please ask, put them into the chat box. Okay, Pushpa, you want to say something? पुष्पा आपने हाथ उठाया है, आप कुछ बोलना चाह रहे हैं? Okay, okay, yes please.
ये मुन्नी है, सी इज मुन्नी। मैं आप देख सकते हैं कि इसको कितना तबीयत खराब है इसका, सी इज HIV पॉजिटिव पेशेंट, और ये बोलने में असमर्थ है, तो इसीलिए इन्होंने कहा कि मुझे बोलने के लिए, तो मैं इनसे पूछ रही हूँ कि आप कुछ बोलना चाहते हैं? नो, सी टॉक नो।
Okay, thank you Pushpa. So this is like, she's Munni and she's just, Pushpa is showing how she could not speak because her face is swollen, and Pushpa asked her if she has any reflection, if she wanted to share anything. So yeah, thank you Munni, and thank you Pushpa.
Thank you Di.
Okay, so now we move to our next session of the webinar, that is question and answer. So we received one question in the chat box, and that question was to Shiriniwas. Shiriniwas, I did forward that question to you. I did assign that question to you. Did you get it? Or I think I'll read that question. So the question is, many of the faith-based organizations are not pro-women and it has its own biasness. So the question is, what would be the most influencing factor for breaking these biases?
So I'm assuming this question is to me, right?
Yeah. I think I did assign that question to you. Yeah. Did you get it?
Thanks. So okay. Yes. So yes, you are right that faith-based organizations at times have shown to be not very women-friendly, but in our experience in the Northeast, we've seen that they're quite inclusive. So I'll give you an example. So in some of the areas where we found that pill pickups for PLHIVs was becoming difficult for them to come and pick it up, we spoke to some of the pastors and they agreed to distribute, and after taking into account all the consent and confidentiality issues, we agreed, and they agreed to pick up the pills and distribute them. So they started acting like what we call the community ART refill groups. Similarly, when we're talking about harm reduction for injectors, some of them have started working with the female injectors and the male injectors and giving them the OST therapy that is important for harm reduction. So, it's not that we have found any of our partners who are faith-based organizations in any ways biased in terms of gender. But yes, one of the biggest problems comes when the issue of morals come in. Sometimes they become a little moralistic, and that is a challenge. So finding the right mix of people and trying to figure out what is best. So what we do is we offer them a bouquet of choices. Either they just talk about preventive approaches, or they act as secondary service provision points, or they act as counselors. So there are different SOPs that we have developed, and which we tell them that you decide what your congregation likes to do or what you would want to do, and then give them the choice to take it forward. It's not easy, I agree. You're mute, I think. I can't hear you.
Thank you, Shiriniwas. Thank you. So, I mean, like any other questions, if participants would like to ask, they still can put it in the chat box. So I don't see the question here. Maybe I think I can ask one of the presenters to share their reflections from today's webinar.
Yeah.
Patricia, would you like to come?
Yes, I found very valuable the presentation from Muni, because it brings a lot of information about how the HIV issue is in India. And I think it's not because it's a sex worker, but I think maybe similar to other women with HIV in the different communities in India. And yeah, there is a lot of discrimination and violation of the sexual and reproductive rights. So there are many, many things to do in India about that. And I hope that we can improve with this project and with the implementation of the guidelines from the WHO and improve at least a little bit the life of women with HIV.
Thank you, Patricia. I think yes, you are right. So there is a discrimination of their sexual and reproductive health rights. There is a there is violation of their rights. Yes, agree. And yeah, these guidelines are useful document. Yeah. And Deepa, I saw you. Would you also like to come forward?
Yes.
Okay.
Actually, hearing these discussions, getting a lot of positive strength, where we are keeping in mind human right values and perspectives when approaching women's matters. Guidelines such as this will support women who are at risk, are Adivasis, are migrants due to occupation or community style, their lifestyles. Those who have to face stigma of criminalization, who are resourceless. Uh, it is expected that these will lead to better treatment, dignity, and reduced criminalization of women with HIV and other sexual reproductive health issues. This is appreciable, and I hope that they certainly translate to actual accessibility on the ground, representation of affected communities on platforms such as these ongoing discussions, and dignity of individual and community. Yes.
Thank you, Deepa. Let's hope so. Yeah. Okay. So I'll just ask Shiriniwas, do you have any? Would you like to share your reflection?
I mean, I completely understand and I completely realize that there has been the amount of stigma discrimination that we are seeing now and is there. It's there. But I would still say that we have come a long way from the days when we had started the intervention. Stigma is something that is, I think, intrinsic in human nature, and I realized it's how close this was when I tested positive for COVID, and I realized how my neighbors were suddenly looking at my house as if it was a house that had people who were spreading some illness, and it struck me that a lot of times stigma is also self-induced, what we call the self-stigma. So, while we work with the communities, we also look at how our population can lead the programs themselves through what we say the community-led monitoring mechanisms. So when community is empowered enough to be able to talk for themselves, to be able to take actions for themselves, then I think the episodes of stigma and discrimination are less. But India, we can't speak of India in the single breath. India is 28 different countries, honestly. While we completely agree, I've worked across the country on HIV. So while we completely agree that there are certain states that are very primitive, and I will not mince my words when I say very primitive in terms of health infrastructure and particularly HIV infrastructure, there are states where community have taken stellar roles. I heard one of our previous speakers talking about one of our great leaders from Sangli, Meena, and similarly there have been various instances of community groups like Ashodaya in Karnataka or Durbar Mahila Samiti in West Bengal who have sort of led rights movements. So yes, so I mean, in short, just saying that yes, we all are in some way responsible for spreading the stigma around HIV. We ourselves are responsible for that. And at the same time, we are also responsible for curing, the redressal of stigma. Thanks.
Thank you. Yes, agree. Totally agree. Community-based interventions, how they can lead the path. Yeah. So, Manjula, we have the 5 minutes, but I'm sure we can take reflection from you if you have any.
Sure. Thank you all very much, and really very touching to hear some of the feedback we've received, and it's really going to help our work forward. I guess my reflection is, yes, we know that there's a whole range of challenges, and it's not just in India, it's across many countries. And where we have implemented this guideline, where we've worked with the national policymakers and donors and ministries and communities, there are some communities that fall through the gaps and that have the worst health outcomes sometimes, and certainly some of the worst experiences within health facilities. And Indigenous populations are, really among the migrants, transgender, incarcerated people living with HIV. There are people for whom we need to do better. It's one thing to have community engagement and their voices heard. It's very important, and as I've mentioned, it was something we felt was critical to the development of the guidance. But I really would like to emphasize that it's not about placing all the responsibility in the hands of those who are actually already so vulnerable. It is also for governments and ministries of health and donors, to finance some of these groups, to be able to give them the tools that they need to be able to themselves advocate for their health, but also for health systems to build better hospitals, better roads, better access to health care. So, WHO's sort of 3 main strategic priorities is, 1, to improve universal health coverage, to really help improve health coverage for all. Improve for people who are in humanitarian settings or in crisis settings, to improve their quality of care, but also moving beyond just sort of an approach that's focused on disease, but to improve health and well-being. So in order to promote all this sort of people-centered approaches, improving that primary health care and health coverage, we need to be able to tackle the needs and the rights of the most vulnerable, and that includes those Indigenous women, those girls, and the gender diverse individuals who are often facing who could have better health outcomes if they had the proper and supportive environment. Thank you.
Completely agree. I completely agree. I think thank you all for your wonderful presentations and sharing your reflections. I think we will move next. Can we have a next slide, please? Yes, so before we close, I think we have already shared that the recording and presentations will be shared in the coming days, and they are also available at the SCAN website. And next slide, please. And for more information, please make note of these 3 websites for WHO guidelines. So here is the link, and for the CAN about this project and this whole initiative. So you log into the SCAN website, and then there is this, like, for additional resources, WHIB network website. And next. So now we are in the last bit of the webinar. I'll invite Nisha Rani from MARG to give a vote of thanks. So Nisha is a development practitioner. She's coordinator with MARG, and she has extensive work experience of working with various grassroots organizations. And I'll invite Nisha. Nisha, over to you for vote of thanks.
Thank you, Sanjita. Thank you so much. So good evening, all of you. I really thank everybody who have attended this webinar, and on behalf of MARG, I thank you all. I show deep gratitude to all the speakers who have spent their precious time in this webinar. I thank Ms. Deepa for her welcome note and presenting the context of Indigenous women living in India, and the cultural and local practices that they use in ensuring the good health. So I thank you, Deepa, and I also thank Ms. Patricia for sharing the overall goals of the CAN project and how this project is addressing the crucial questions for the women living with HIV living with HIV. I also thank Ms. Manjula for sharing the guidelines of WHO and the process, that participatory process that has been taken care while making this guidelines. It makes this guidelines very inclusive. So thank you so much for this. And I thank Mr. G.S. Shiriniwas for presenting the specific case, one can say, of Northeast, that what kind of challenges the geographical context faces in operationalization of this kind of guidelines. And definitely it is a very unique space where not just the health infrastructure in terms of health facility, but the entire community has very unique context, and the culture is very different. So it was really enriching experience for us, for I think everybody. Last but not least, I thank Ms. Muni for presenting the ground reality and sharing what it takes to implement such practices in the community who live with stigma and taboos, but they thrive to live. Thank you so much.
And thank you all the participants for joining today. Really, really thank you for your participation. Yeah.